Okay. Yeah, any of you who have attended our webinars in the past know that we record them and then we put them up on YouTube, our YouTube channel, and on our website, so that they're there for future reference, or anybody who wanted to attend and had to miss, or for the people that you tell how great it was and you want to pass them on the link, right? You'll also get the recording sent to you in an email after it gets uploaded and all the stuff that has to happen happens to it. So it'll be a few days. Okay. Well, welcome. Thank you all for showing up. I'm excited about this topic and our presenters, especially. I think most of you know me. I'm Sue Mackey, and I'm president of the board for the Funeral Consumer Society. My vice president, our vice president, Jill Ross, there you go. Jill had been president and is now vice president, and I had been vice president, and now I'm president. Anyway, this is just kind of a group effort here, and Jill is going to be facilitating our discussion mainly today, but this is going to be a very open presentation. Our two presenters will do a brief presentation, and then it's going to be open for questions. And there are lots of questions about hospice, lots of misunderstandings about hospice, a lot of myths about what hospice is and isn't. So I hope that this program will give you some clarity and also some insights about hospice and when it's appropriate. We're fans of hospice in that so many people do not avail themselves of hospice until the very end, and our medical system plays into that because physicians often just don't. Some consider hospice to be giving up. Like, I have nothing else I can do to help this patient, or more hope to hold out. And so they hesitate to even bring the subject of hospice up. That's a whole nother discussion, but it's not uncommon for people to come onto hospice in the last 5 days of their life, when in reality, people qualify 6 months before an expected death. And there's so much good that can come from hospice that it's just a shame that people often don't avail themselves of those fine services that are supportive to themselves as a patient and also supportive of their family, because of not really understanding what hospice is about, and that hospice is about supporting life up until death. So I would like to share with you a little bit about our presenters. Kimberly is online now, and we're expecting Kenna to pop in soon. But Kimberly is the Regional Director of Business Development for Adobe Healthcare. And sorry for the papers rattling, but I don't have this memorized. She's Regional Director of Business Development for Abode. She began her career in a rehab setting and has worked in most areas of healthcare. She felt a calling to the privilege of end-of-life care and finds it a great honor to empower families and patients in their education around the holistic, comprehensive nature of the hospice benefit. She earned a degree in communications and psychology from Colorado Christian University, and she and her husband have 26 years of marriage have 3 children, and a daughter in heaven, a daughter in PA school, and a son in college. When not serving her families and her team, she enjoys anything in the Rocky Mountains and spending time with family. Since I don't see Kimberly Kenna on yet, and I'm gonna disclosure
Kenna's on, Sue.
Oh, is she?
Yeah.
On the other Perfect. Okay, Kenna, welcome. Thank you. So let me introduce Kenna, and on disclosure here, Kenna is Jill's daughter. So it'll be fun having the interplay between the two of them as facilitator and panelist. Kenna Uddenberg earned her bachelor's degree in psychology and nursing from Washington State University and moved to Colorado in 2018 to practice nursing. She worked in a psychiatric hospital for 4 years, then switched to hospice, providing end-of-life care for individuals and their families in community and home-based settings. Kenna currently works for Bloom Hospice in the Denver metro area as an on-call triage and field nurse, and has experience in hospice case management and admissions with a previous employer. She believes that an individual should die wherever one calls home, that healthcare should be individualized and collaborative, and age-appropriate death education is paramount to changing the death culture in this country. Kenna lives with her boyfriend and 2 senior rescue dogs in Lakewood, and spends her personal time volunteering with animal welfare organizations. So welcome to both of our presenters. My thanks and our thanks as the Funeral Consumer Society for your sharing of your time today with this education. And I'm imagining most of you are members of the Funeral Consumer Society. If you aren't, we would welcome your membership and or donations to support our work. We have started this webinar series about almost 2 years ago. It's been really well received. We're excited about the education that we're putting out there as far as with the webinars. We are also available to do funeral consumer education in person. If it's somewhere in the Denver metro area, because that's where most of our board members live. But we can also do education across the state because of Zoom. So that's what we're about, is educating people on how to be wise funeral consumers, making purchases for something that a lot of us don't ever have to do. And most of us will do very limited number of times in our life. And it can be an overwhelming and mind-boggling type of experience if you don't have some familiarity with the jargon and the way that the industry works, et cetera, generally at a time when you're in grief and compromised mentally, psychologically, et cetera. So if you have other questions about Funeral Consumer Society, jump in and ask those also. But for now, I would like to just turn everything over to Kenna and Kimberly and let you guys do your thing. I think, like I said, they're going to do a relatively brief presentation. Feel free to raise your hand if you've got questions. For those who are off screen or whatever, feel free to use the reactions button and do a hand raise in your little square. And also you can use the chat. We'll try to monitor the chat and make sure that everybody's questions are answered. Okay, I'm gonna turn it over to Kenna and Kimberly. Whatever it is you're gonna do, Jill is gonna be facilitating.
Yeah, whomever wants to go first. I just want to thank everybody for being here. This is a topic incredibly important to me. Again, just with the hospice benefit. I actually work in senior living. I'm a sales director for a senior living community, and I hear the misinformation all the time. And that's why I loop in Kimberly with questions and my daughter with questions. And so that is how this webinar was born, out of those questions that I've gotten, that I have of the experts. And information is power, and we want you all to have that. So I'll turn it over to either Kimberly or Kenna. I think, Kimberly, you were going to go first.
I will. Yes.
Thank you.
Thank you, Jill. Gosh, I appreciate being here today. And, Sue and Jill both touched on things that made this a passion and a zealousness to speak to today. When I had an unexpected death, it was Jill that I called to say, walk me through this funeral world. Kenna came to join me from her psych world of nursing to hospice, and we, in a very nice and polite way, call her one of our baby nurses, but far became one of our seniors. And so I'm partial to just, it's really easy for Kenna and I to do this. We've done this together again and again, but I just want to open today and give you guys just an overview of what hospice is. And when Kenna and I got together to discuss this webinar, we really realized that a lot of our conversations are lent by families, because some families have had a personal experience, and sometimes that's not good. A lot of times they still think that hospice is 1983, where you go to a place to die. And so a lot of our education is really debunking those myths of what hospice is. But it is a benefit to most that's provided through your Medicare. That being said, you can ask for hospice at any situation. Where a patient has a life-limiting disease of what two doctors term as 6 months or less prognosis. That being said, and Kenna can speak to this clinically a little more, we don't know each person's timeline. And really what hospice is it's a shift from aggressive treatment to comfort measures. And the beauty of that is, and in that shift, whether it be a patient oncology or dementia, you not just only get a nurse that comes in and sees you, you also get an entire circle of care with chaplaincy, social work, CNA. We have usually robust volunteer programs. And then that team is available to you 24/7. And Kenna will talk a little more about what that looks like because she knows the clinical background of that. But those services are all provided for comfort. And what families a lot of times don't realize is in the narrow vision at the time, you're thinking, oh, the clinical idea of comfort. But no, it also is the emotional and psychological and spiritual support of comfort. And one of the things I love most about the hospice benefit is post-death, we actually have bereavement services that follow family members for 13 months. And the reason that's important is because as a caregiver or a daughter or son that are trying to get mom or dad, or even for me, a child on hospice services, you're the advocate. What you don't realize is when that process is done, you still have this team that's going to support you and check in on you and walk you through those 13 months post losing your loved one. So that's really important. People ask a lot of times, well, when is hospice appropriate? And a lot of times that question is specifically to dementia patients. And we see that a lot, there's such a changing condition, but yet it's maybe not trackable. And really when we say hospice is appropriate is when there's no curative measure for that patient. And that's what we educate to. There's also palliative care, which is a bridge to hospice, where families perhaps want to seek that aggressive treatment, but also want to use the psychosocial support of hospice. Each of those look differently. I always tell family a lot of times we go back to really educating and empowering them of what palliative is and isn't, because sometimes people are just hung up on that H word of hospice. And that's where we want to give them comfort and understanding around that. Care is provided in the home, in a community. For us, it was in a hospital setting. So that's another thing. A lot of times families don't realize, they think, oh, well, my loved one's going to have to leave the home. No, absolutely not. Their benefit will provide what we call durable medical equipment to create wherever home is as their place of care. So the hospice benefit, and all of this is free to the family, is, if they need a bed, if they need over the bed table, oxygen, all medications associated to that diagnosis. All of that is part of this benefit. There is no charge to hospice. And if there is, you need to raise the flag because something's going on. Hospice is completely covered by that benefit. So wherever home is, now let's say Jill and I've had this where we've had a patient in crisis. We weren't able to manage the pain. It was not the best to leave them at, whether that was their senior living at home. Hospices do have contracts for inpatient hospice care. And that's where we will move that patient there, again, all on the charge of us as a hospice team. And we will begin to have round-the-clock care. And Kenna, you might want to talk about those different levels with GIP and continuous care. We kind of discussed about who was on the hospice team. We each, as a hospice, have a medical director. That being said, if your medical doctor wants to follow your loved one's care, they are able to do that as well. That's a question we talk upon at admission, but we do have a medical director that watches and guides the care of all of our nursing and clinical team, and is the doctor for the patient. Some of the myths, so you kind of talked about that. People think, oh, well, I should wait till the last few days. Oh, That's the one that just breaks my heart. This is a benefit that is absolutely available to you. And we would say the earlier, the better. And the reason we say that is because you get to build trust with a team that's going to be there with you as you see, the course that hospice take. People think all the time, oh, my loved one comes on hospice and this is going to be the course. That's not the case at all. Hospice does a lot of ups and downs, and when you have a team there, you can kind of have the assurance of, hey, I'm seeing this today, because there is that anxiety of, oh, are we in the final days? And your hospice team is able to speak to that because they're seasoned and educated to know that sometimes we see a patient rally and they can rally for several days. And sometimes, what that looks like when a patient stops eating and how we educate to that. You have this entire team that you trust that can guide you through that journey. I see a question, Sue. Is that something I should touch upon now? I didn't.
Yeah, I do see that too. You sure can. I think that certainly we would encourage questions in the chat. It's when you say benefit available to you, do you mean through insurance or some other financial service? Can you touch on that, Kimberly?
Absolutely. So the majority of our patients at-home hospice, if I'm brutally honest, are of the age of Medicare benefit. So that is why we talk about the Medicare benefit. That being said, you can have people with a diagnosis that's life-limiting that's on Medicaid. That's covered. And then most of your insurances do have plans. I've had a 41-year-old patient that had United Healthcare. We had to go and get an authorization. But what I want you to hear about it is not out of pocket payment for hospice. The other thing is, if you have a situation where you do have a young family member or they do not have access to Medicare, do your due diligence. A lot of hospices will take patients on pro bono. And if they can't, they will find you a hospice that does. So payment should never be an issue. Our typical patient does hold the Medicare benefit. Sometimes we get people that are out of the country that don't have Medicare. Also, there's always pieces of the puzzle that you may not necessarily plan for, but you have a team that will jump through those hoops for you. This is a service that should never cost the family anything.
Thank you, Kimberly. Yes, so it is covered in commercial insurance, Medicare, Medicaid, as well as pro bono cases, with a hospice being willing to take a situation where it's at need without payment.
Absolutely.
Good, thank you.
Yeah. The other myth that I think people think, and that I sit with families a lot, is if I go into hospice, I've given up hope. And that's just something that just isn't the case. And that's why I loved what this was titled, was Hope in Hospice, because honestly, hope is something to look forward to. And we don't say that hospice, we sit around and talk about death. We talk about life. And most of your hospice nurses will tell you that, that's the question they'll get all the time. When is my loved one going to die? And, we put that as a myth because none of us know that. And we're here to talk about your loved one's life as well as the family circling them. So there is a lot of hope in the work that we do. And I think sometimes that's misunderstood. So that's something really near and dear to me. And I know Kenna can speak to that as well, is that, yes, we might be in the business of death, but the reality is we talk about life. The beautiful thing about hospice too, particularly in the home and even a lot of communities, I think Jill could speak to this for senior living, is it gets to be personalized. At that point, if mom says, I just want ice cream for breakfast, lunch, and dinner, well, then I'll be it. Let's do it. You really get to craft that care plan to what your need is. And a lot of times your loved one says, I don't want to do this. I don't want to do the therapy. I just want to be comfortable. Those are all indicators that would tell me it's time for a hospice conversation. Because really our entire goal of hospice is that your loved one face their last days, how many that is, none of us know, with dignity. And that should be the pursuit of the care in all arenas. And so really educating to that, because, as caregivers, we're advocates to keep making sure they're healthy. And it's just a mind shift to what that dignity looks like. So, that's a Hospice 101. Briefly, that's a Snapchat. I hope that that gives us some questions. I'd love to introduce Kenna and have her speak to what it's like clinically to serve beside those patients. The other thing Sue and I discussed, Kenna, is MAID. So maybe there's an opportunity to kind of talk about what that is for Colorado in the hospice benefit and MAID and assisted in dying. So I'll open the floor to you.
And just so everybody knows, Kenna is on call nights. So she is 5 p.m. to 8 a.m. Monday through Thursday. So she's responding to those calls in the middle of the night, whether it's home-based or community-based, and just really what she wants people to know. Okay, turn it over.
Hi everyone. Like Sue and Kimberly, my mom, have said, I'm Kenna. And I was in nursing school 5 years ago, and even then there was not a lot of conversation about hospice and palliative care. When we were talking about geriatric healthcare, it was very much geriatric healthcare in the hospital setting or in a skilled nursing facility, which is still usually medical treatment. And so a lot of what I've learned over the last year is from my patients and my families and from Kimberly. Most of this is not what I learned in nursing school. And that's pretty unfortunate in terms of medical and nursing education in this country. So thank you for letting me learn with all of you and share what I've learned. So the nursing role in hospice, like Kimberly said, there's a nurse case manager and an RN case manager during the day, who's a family's and community's point of contact. And then outside of business hours, you have your on-call team. So that's me during the weekdays, it's other groups of nurses during the weekend. And we respond to families and communities when there is a question or a concern or a death or a change in condition. And so we really are doing a lot of that. Like what Kimberly said, a lot of trying to navigate those changes in condition, and how do we focus on the life part of that conversation instead of the death part of that conversation. And so yeah, so sorry, I have a lot of thoughts going in my head, and then trying to articulate them sometimes is a little difficult. But anyway, plus I'm tired. I saw the question pop up of like, when do you sleep? I nap a lot. I don't get a lot of sleep like in a row, so I nap a lot. So then that's also playing with this. And really for me, what is so valuable about hospice is doing it where somebody does call home, and being able to like critically think about what that means for that patient and that family, and how do I try to keep them in their home wherever that may be as long as possible. So a lot of times at night there is a change in condition, so meaning pain or anxiety or agitation, and the tools that I have available are not working. And so like Kimberly said, there's different levels of nursing care within hospice. So a routine level of care is providing care wherever that person calls home. And then we have continuous care. So that is 8 hours of nursing care in a 24-hour period where we are managing a symptom, and it's usually pain. And then if I cannot manage, or a nurse cannot manage that in 8 hours within a 24-hour period, then we escalate to general inpatient hospice care, which is in a contracted inpatient hospice facility. So like Lutheran, like the Collier Inpatient Center at Lutheran or True, or even a hospital, like a medical hospital, we can contract with them. And then that individual becomes both the patient of that inpatient facility, but also we still maintain them as a patient. So then they get even more people involved in their care. That is kind of, so that's a level of nursing hospice care. And then something I'm glad that Kimberly brought up, Kimberly and Sue talked about MAID, because that is something that I didn't even realize was something that we could do within hospice. And I should say, since hospice is a Medicare benefit and MAID is not federally legal. So MAID is legal in Colorado, but it is not federally legal. So
medical aid in dying, for those that aren't unaware. So acronyms, yes. So medical aid in dying.
thank you. So how each hospice wants to approach that is different. It is possible to do medical aid in dying when you are on hospice, but the role of the hospice nurse is different with each company. But it is absolutely possible, and it is something that a lot of people do want to explore. And so then the hospice team can help them navigate the Colorado MAID regulations and how they can do that while still maintaining their hospice benefit. For me, this is perfect, because last night I was at 2 deaths. And I promise I'm going somewhere with this. So the first one was Alzheimer's. She had Alzheimer's. She was on hospice for 6 months. She got the full benefit of what hospice should be. She got that 6 months of rapport building with her hospice team, quality of life with her family. She got to say, well, in her own way, she got to say all of her goodbyes. She got to have closure. And she truly embodied what the hospice benefit was. And if someone's on it for a long time, then I get the chance to meet them, because I don't always, I'm coming in at night. I most of the time I haven't met the families that I'm visiting. I haven't met the patients that I'm visiting, or but with her, I'd seen her a few times throughout these 6 months, and I'd met her family. And so when I was at her death, it was, one, a little bit more rewarding for me. And also the family was like, oh, I know you, we've talked on the phone. And then I was at a death, my second death last night. He was only on it for 5 days. So unfortunately, his hospice journey was not fully embodying the true benefit. It was still a fantastic death. His family were coping so well. They were sharing stories about, his time with his wife in Chicago, and they were talking about the mob, and I learned a lot about Chicago and the mob. But just 2 very glaring examples of how the benefit can be utilized in different ways. And I obviously wish that this gentleman had been able to be on hospice longer. But I'm glad that his family was coping well, even though he was only on it for 5 days. Sorry, I'm looking at this question that just popped up.
And
I'll
Kenna,
read
can
it.
we,
Oh.
can we also touch upon the fact, Kenna, that the hospice benefit does not expire, and what recertifications look like?
Oh, yes. Thank you, Kimberly. Thank you. The agenda we talked about is coming back in my head. Yes, so like the hospice benefit does not expire. So if you elect hospice, you can leave hospice at any time. And then the Medicare, your Medicare just reverts back to normal medical treatment in a hospital. So you can be hospitalized for one of these, symptoms or a change in condition. You can continue with your specialists. And then when you feel like you want to come back on hospice, you can come back on hospice if you meet that criteria of your attending provider believing that you meet criteria, and then the hospice physician also agreeing that you meet criteria for hospice. And that's what we do a lot of the times at night or on weekends also, is someone falls in the middle of the night and they split their head open. On the hospice benefit, we're not treating that. We're not treating that brain bleed. We're just making sure that you're comfortable in wherever it is that you call home, and that's with medications. But a lot of the times families are like, oh my gosh, you're on hospice. My parent is on hospice for Alzheimer's, not for, so they have this vision in their head of like, okay, I understand what someone on hospice and what the normal progression for someone with Alzheimer's should look like. But I didn't think about the fact that if they fall and split their head open, they wouldn't be getting medical treatment for that. So a lot of the times family will revoke. So then they go to the hospital, they get treated for their head injury, and then we can admit them back on hospice the next day or whenever it is that they're discharged from the hospital. This benefit does not expire. It's not like if you use up your pot of Medicare money for hospice that you can't come back on. And that is a lot of the times families need that kind of closure of we did everything that we could. There was this one last medical event that we wanted to try and treat, and we are okay now. We are okay now with truly aligning with what hospice means. And enjoying the remainder of our loved one's life and wherever it is that they call home.
Kenna, thanks. I'm going to actually read the question in the chat, and probably both of you could answer this from different perspectives. But if you are interviewing various hospice teams to see if there are groups that are more aligned, what are some questions you might suggest asking about ways care varies from team to team? So this is huge. This is an incredibly important question, because whether it's medical aid in dying, because not all hospices will do and support medical aid in dying. And also Colorado is not a certificate of need state. So anybody can hang a shingle with some guidelines, call themselves hospice, and they don't have to prove that there is an audience for a new hospice. So hospice can become very car salesy. It can, and I've seen it in senior living. I've kicked people out of my building because it was more car sales than compassion. And so that is a fantastic question, and I appreciate it. So Kimberly and Kenna, kind of your thoughts around what questions to ask as far as, philosophical alignment.
Sure. Yeah, I will start, Kenna. The biggest thing I would ask if I were looking for my loved one is, will I have the same team from beginning to end? As Jill just referenced, there are hospices, I think we're up to 211 in the Denver market, where you can have an RN case manager who's also doing your on-call, who's also doing your admissions, and maybe doing your marketing. And the reality is you want to have an organization where you have a circle of care that is your circle of care. And unless there's a circumstance like a nurse goes on maternity leave or their territory becomes too big and we strategically need to move, that would be really important to me, that I would ask the hospice if they had a team that would be with me from beginning to end. The other thing is you can go onto Medicare.gov and look at the star ratings of hospices. I encourage every family to do this. I also tell every family, you know what, don't just interview me. I would say do your due diligence and talk around, because at the end of the day, you can meet someone that tells you about the hospice benefit, but then you could have a nurse show up that maybe didn't share the compassion of the person that described the benefit to you. So it's okay to ask to meet the nurse that's going to be doing your care. In a senior living setting, I put my grandmother on hospice in Oregon. I asked the senior care, who do you work really well with? I think that's a really important question, because if your loved one is having a pain crisis at 2 a.m. and they don't have nursing on staff, does their on-call team have a go-to hospice? Because that means they've done this before and they have a routine and they know what to expect. And the last thing that I would ask that's important to me is, do you have a foundation? A lot of times after losing your loved one, families like to give a gift to the hospice care. And that is where we see that foundation utilized for different loved ones' needs. The organization I'm with right now, we're getting ready to send a family to Disneyland at this grandmother's wish. That to me is important because we all know Medicare dollars are sacred, and we want to know that they're used wisely. And when a hospice organization puts the effort into creating that foundation, that speaks to me the volume of their patient care. So those are just some of the things that I would say. In a hospital setting, it looks a little different. You do not get a true clinical team based on my experience. You might have a hospice team, but you still are the advocate to make sure that your loved one is not having unnecessary tests and things, because you as a family are advocating that you've moved to a comfort model. So in the hospital setting, it looks a little different. Kenna, is there something you want to add to that?
Yeah, a couple things, and these are none of these things I would have thought about until I have been a nurse in hospice. So obviously healthcare is business. Hospitals want to make money, hospices want to make money, but hospices don't have to take on patients the way hospitals have to accept every patient that comes into their emergency department without getting a fine from Medicare or JCO or whatever. So what's the ratio of a nurse case manager to a patient? I want to know that. If it's like, if it's like over 20, that's like not okay, because you cannot, one nurse case manager cannot give the best care to 20 patients in a week. You know, the sweet spot is somewhere in the low teens. I want to know, does the hospice medical director, is his or her only job to be a hospice medical director, or do they have another job? A lot of hospices, their medical directors are primary care providers, and they run their own practice, or they're specialists in a hospital. So their availability to their nurses is very limited because they have a second job. So making sure your hospice medical director, that's their only job, so that their nurse can get a hold of them pretty instantly. And then I think the other one is like, geographically, how spread out is that hospice? Because a nurse case manager, generally their territory is within, you know, maybe a couple cities in the metro area, or, you know, a couple neighborhoods within Denver. But your on-call team has to drive all over where you have patients. So how many hours or miles is it going to take your on-call nurse to get between visits? I think those are kind of my three things that matter to me in terms of hospice employment. Who am I going to work for? Because I don't want to work for somebody where I'm not able to give good patient care. And so, yeah, those are the three things important to me.
No, great. And we have a couple more questions in the chat, ladies. So CK asked, how are single folks without family handled? A large percentage of boomers. Also, are staffing shortages a problem with local hospices? So both of you, yeah, whomever wants to jump in. Thank you. Great questions, everybody. This is what it's all about. We like to have it be dynamic this way. So appreciate the questions.
Absolutely. And Kenna's going to add to this, because Kenna can tell you she could go get a job anywhere, anytime tomorrow. Absolutely, there are shortages in Denver. And that's why it's key to really know the team that you're having come in. You know, those of us that have been doing this a long time, a lot of us will say it's who we work beside instead of who we work with. And that's kind of what nursing shortages have produced. Obviously, when Kenna didn't join my team, with tears in my eyes, I said, go do what's best for you. And she's getting to live that great schedule right now. But nursing shortages are a problem. That being said, a responsible hospice is not going to take on patients they cannot staff, and that is okay. Jill referenced earlier the sales of this business. There's not sales. There's compassionate care that needs to be given. And if you cannot give good care, a hospice should be able to say, we cannot admit this patient, but we're going to refer you to a partner we trust. Jill and I we've been doing this for years in the senior living setting, where you have nurses that caseloads get too high, and the nature of hospice is you can have caseloads too high, and then tomorrow can hit and you can have 4 deaths the night before, and it can change. So don't feel like if you ask at one time, what is your nursing patient ratio, that's going to stay there. It could change in 4 hours. If this is a hospice you align with and you want to support, say that if it's not imminent that your loved one needs to be on right that minute, it is worth waiting for the right hospice team. As far as single folks, that is the beauty of our entire clinical team. We didn't really reference what their jobs were. Obviously, Kenna represents the clinical standpoint, but our social worker is there to aid that person and what a good death process looks like. If they are home alone, they are a resource to them to say, you know what, maybe you're not safe home alone. Can we get you non-medical, or can we get you more support in the home? But your social worker is really the driver of that ship so that you're not left alone to make these decisions. Let's say you don't have your end of life planning in order. He or she can walk through that with you, connect you with the right mortuary, connect you with the right attorney. So all of that is part of that social worker support that kind of helps in that psychosocial end of life care. Kenna, do you want to add to that shortage and maybe what I haven't discussed on how we support single people?
Yeah, and Kimberly's very eloquently explained the staffing shortage part. So yeah, I agree with her. Just hospices shouldn't be admitting if they can't care for that patient, and we'll refer to one that we trust. I think in terms of a single person, either living alone or even in an assisted living, and they just don't have family. That's what the social worker is for. And there's different ways that we can place that individual at end of life, if that is what is going to be best for that individual, whether it's in like a respite center or in an inpatient hospice setting, so that they can get some management at end of life. Or you are totally allowed to stay in your home, and we will figure out what that looks like. If someone is single and they don't have family and they don't want to leave their home, we will figure it out. It's just kind of dependent on what that individual wants. But we have ways to problem solve that.
And Kenna, I think I can piggyback right on that when it talks about what revoking hospice benefit looks like. I think that's important, because if your loved one is being told they can't stay at home or they can't stay at their community and you're not seeing resources provided to them, it's as simple as signing a piece of paper that says, I revoke. Sometimes that's utilized when a loved one graduates, and we don't talk about that very often, but we do have people graduate off the benefit. We do a recertification process every 90 days. And let's say your loved one had a recent hospitalization and had really looked like hospice was appropriate, and then we got this circle of care around them, and all of a sudden they improved, and they were no longer needing to be on hospice. That's when we would revoke them as well. So that process is very simple. If you are caring for a loved one out of state, we do it through DocuSign, but not a big deal at all. The other thing I see here is nonprofit versus profit. Oh, well, in the hospice world, what we would say is there's no such thing as a nonprofit. I'm just being honest. And that's because maybe I've worked for profit hospices for years and years. It kind of goes back to that foundation piece that some people utilize that differently, and they can have a side of their hospice that is not for profit. We're all the majority of us are getting paid through that Medicare benefit. So that's kind of a loose term in the Denver market. I also work in Arizona, where we have the largest not-for-profit hospice. Again, I'm sure there is a vein of not-for-profit care, but the majority of care provided is paid by the Medicare benefit, and it is producing an income for that, a revenue rather, for that organization. Kenna, do you want to touch on that? That's a good one, but that can be sometimes a tricky sticky.
Yeah. And I think I didn't really think about this until recently, but hospice, since it is a Medicare or a Medicaid or a VA or a private insurance benefit, it doesn't matter what your socioeconomic status is. It doesn't matter where you live. None of that matters, because you get the same health care whether you live in an income restricted apartment on Colfax or in Highlands Ranch. So in terms of this not profit for profit conversation, people with less resources are still getting the same hospice care. And I think that that's truly what matters in hospice, is that everybody's getting the same amount of care. And full disclosure, I've only ever worked for for-profit hospices, so I will acknowledge that. So I don't know from a nursing or clinical standpoint what it would be if there is a difference. But that's just, I think hospice is very much, aligns with social justice nursing, and, regardless of the profit or for-profit status.
Can I also point out that a nonprofit does not pay a penny of taxes to your community because of their nonprofit status? And I know locally of a nonprofit where the director was receiving $250,000 a year salary, and the for-profit hospice I was associated with, if the director was making $60,000, it would have been a lot. They were in it, for their heart. So I think what's most important is doing your good evaluation of any particular hospice, whether or not they're in alignment with your values and they have nurses, good nursing staff ratio, and all the other things that you two are bringing up as far as questions to ask. So.
And I would ask who they're owned by. I mean, that's really key. For those of you that don't know, in the last 10 years, private equity firms have gotten into our hospice buckets. Sometimes that's great because you have the umbrella and you have the financial backing of really good care. Sometimes it's not. So honestly, as we've referenced several times this afternoon, just really feel like no question should be off limits when you're interviewing for this type of care. It's the most important dignified care available. Do your homework. And if you can't, rely on a friend and say, reach out to Jill, reach out to someone, they'll give you the questions to ask, but feel that no question should be off limit for you when interviewing a potential hospice.
And I think certainly the hospice interview aligns with Funeral Consumer Society of Colorado's mission. Interview funeral homes. I mean, we give more research, we get more research in a car. We give so much research, consumer reports up the yin yang about a car or an appliance, but we don't when it comes to end of life. And I think that's so unbelievably important. Somebody in the chat, I think it was Gary in the chat, shared just a heart-wrenching story about his poor experience with hospice and his wife. And I'm so sorry that happened to you, because that really is such a negative for all hospices. But yes, that's why I'm so grateful everybody's on this call, because we want to empower you to have those conversations in advance, so you are not doing it in the height of emotion. And that's what this is all about. And to have those conversations so that you're like, what if? I love it when people what if me to the moon and back, because I can talk this through with you. We had another question. Yes, Jim and Judy, I think with the recording, it records the chat. So those chat questions will be on paper or in the recording, or we can cut and paste them. Kenna, Kimberly, and Jill from Galen, could you please suggest sources to find out about volunteering in hospice. Yes, that does exist, and it is just amazingly wonderful. And what, if Kenna or Kimberly can speak to what that looks like, and that's part of the support team.
Absolutely. This is something that just makes me so proud of our Medicare benefit. We are required to have a robust volunteer program. And that can look like I've contracted with a group of seamstresses that have made little aprons with busy gadgets for our dementia patients, to another gal that brings her therapy dog into the community, to another individual that just likes to read. And a lot of people, you know, at end of life just want the extra support and someone present. So yes, Kenna and I, both of our agencies have volunteer programs. We can put our emails. We would love anyone interested in that. It is a gift, and the beautiful thing is you can bring your gift. So whatever you want to do, you can kind of volunteer in that aspect. In Arizona, I have a little miniature horse that goes into communities, and this gal likes to take her horses and have this kind of socialization. So I can speak for Abode. Ken, I'll let you talk about Bloom, but we have a very robust, and one of the things we haven't talked about is our regulatory measures of hospice. But when we have our state survey come in, that is one of the things they turn inside and out. And I would ask in an interview process about that volunteer, because we will be what is considered tagged by the state if we do not have that program running. It can't just be a myth. It's got to be a substantial program. So that's important. Just because I'm on it here, Jill, the other one is if someone wants to. Okay, very good. This is a myth as well. Sometimes people think hospice is 24/7 care. So let's talk about that. That is not the case in hospice. And Kenna is going to really be able to speak to this one after hours. But your hospice nurse usually comes about twice a week. Each agency is different depending on your need. You could see your chaplain once a week, or your social worker. Your CNA visits are regulated by what the care plan needs. So if you need to be seen by that CNA 7 times a week, then by all means that should be met. But no, we are not 24/7. And that's where we lean on our support services to create a care plan that is to keep the person safe. But referencing back to what Kenna said earlier, if you are bound and determined to be at home and that's what you want, we will find ways to make that happen as well. So it is a delicate dance, and there is tension in that of what everyone deems safe to be at home, but we are not 24/7. And most of those 24/7 care plans are private paid. There is a waiver through Medicare that's available, but it's limited hours of care. Kenna, do you want to touch on that?
Yeah, so unfortunately, nursing is available 24/7 in terms of there's always going to be a nurse that answers the phone, but it's not 24/7 in-home care as the poster acknowledged. So, and unfortunately at that point, so if someone does need 24/7 care at end of life in terms of medication and symptom management, that's when we would have to figure out, you know, most likely a generalized inpatient setting. So we would have to go through the steps of routine hospice care, continuous care of a nurse being in there providing 8 hours of symptom management, and then we would admit to GIP. That's just the steps we have to go through with Medicare in order to say that someone needs an inpatient stay for end of life symptom management. So that is the case where someone wouldn't get to stay in their home. You know, a single person being able to stay in their home. So that's kind of the unfortunate answer within, yeah, the hospice setting, I guess. And then, okay, and then there was someone else in the chat, and then you also had your hand raised. Cindy, I would like to share and ask a question. Are you still here?
Sorry, I pressed the video off instead of unmuting. Yeah, you kind of just answered it, but it was, I had an experience 12 years ago with my mom with hospice, and she needed to be, her last few days, she needed medication around the clock. And when I arrived, I was kind of, I wasn't prepared for that. I didn't know that I was going to be the one having to give her the medication. So, and it turned out fine, but it was such a shock to me. And I don't know if there are some hospices that deal with that differently. I mean, I'd much prefer that I was the one doing that rather than her having to necessarily be taken out of her home and end up in a hospital somewhere. But what happened was there was, she actually did have round the clock care with hospice, but it wasn't, they were, you know, assistants, and only RNs were allowed to administer the medication. So I just wanted to find out, since that's 12 years ago, and obviously I guess every single hospice has different policies. What are the policies in terms of letting family manage the medication, excuse me, as well as making sure that they have been properly educated in how to do it?
So Cindy, I can talk about the non-medical part, and then I'll have Kenna speak to the education of families administering medications. But in the state of Colorado, one of the things we talked about is providing, you know, round-the-clock care that isn't hospice, that is non-medical. They are not allowed to administer medications. That being said, totally different regulations in the state of Arizona and New Mexico. So just know that that's specific to your state. And that is why we do educate families. But there are agencies within Colorado which carry a Class A license. They can administer medication, but you're going to pay a nursing fee for that, and it is not cheap. As far as educating families on, you know, administering medications, which really is best, Kenna, would you speak to that?
Yeah, and Cindy, you're absolutely right. There is, as much as we try to build a rapport with families and educate, there are definitely things that we sometimes miss. And a lot of the times that is at end of life, when your loved one needs 24/7 medication, family will be the one to give that. And I fully acknowledge that. When I was a case manager, there were a couple times I forgot to mention that. And sometimes when I'm coming in, you know, on call, you know, at night, families are expecting me to sometimes stay there and give those medications. So you are absolutely right. Like we sometimes fail to do that. But yes, what in an ideal world, if someone is living at home, or even if well, not in assisted living, because if it's an assisted living, they have to, the staff will give those meds. But yeah, if someone is at home, their family's giving medication, and we obviously provide all the equipment for that, the actual liquid medication, the syringes. I've like FaceTimed with families while they draw up the medication, and then, you know, I walk them through how to do that, and we verify the dose and that kind of thing. Even though we don't give the medication continuously, like we'll do a first visit where we can show where we will give it and show how to adequately give it and teach families how to do that. So families are absolutely a huge partner in hospice throughout someone's, you know, hospice admission, but especially at that end of life.
Well, let me just clarify. Did I misunderstand? I thought Jill said that in Colorado, non-medical people, family would not be permitted legally to administer medication.
Family can. Family in the home setting can.
Okay, I see.
If someone is at home and they have 24/7 private caregiving, those caregivers cannot in Colorado give the medication. So family, even if they have 24/7 private pay caregiving, family still has to come in and give those meds every 4 hours or 2 hours. Yeah.
Now I understand. Thank you.
We've got a couple more questions in the chat comments. Let's see, what about MPOA, medical power of attorney, being able to provide meds? So Bruce, I'm assuming you mean if they're not family, if they're legally MPOA, but they're not family? Can
Correct.
they provide meds?
Absolutely.
Yes. So it's
Really the no-nos are when you're hiring an agency, it would be deemed what's called a B license, and that would be a home instead visiting angels. Those people have had no training. That is what the state does not like to see. But family, friends, absolutely, and totally appropriate. And honestly, what Kenna and I would say would be best, because you're getting to control that timing and providing that dignity of care at the end of life.
Thanks.
so I guess some of the nuts and bolts with Kenna, some of the deaths that you've responded to, what has been like, how long has it taken? So typically if it's an attended death, a hospice death, hospice, and correct me if I'm wrong, kiddo, but if hospice calls the coroner can release the deceased to the mortuary without the coroner needing to come. Typically, how long have you waited sometimes for a mortuary response to come and get the deceased? And I also, to piggyback on that, and Sue can really speak brilliantly to this, your loved one does not have to be taken away right away, folks. If you want to hold vigil and you want to have family come in the next day to see the loved one, because once they're in the mortuary's possession, they are going to charge you to see your loved one. So Kenna, back to the question, as far as, family, you calling the family, letting them know that there's a death, how long the mortuary takes, and then also please know that the mortuary doesn't have to come right away.
So yeah, when someone dies on hospice, whether it's witnessed, their last breath is witnessed by staff or family, or they were just found, then yeah, the hospice nurse comes and confirms death. The provider, physician, has to be a physician, pronounces time of death, and then we call the county coroner, and then we call the funeral home. So just kind of like what Jill said too, interviewing funeral homes, not all funeral homes are the same. A lot of the times they have an answering service that answers my phone call in the middle of the night, or they have a dispatch. They contract out their body removal team, so it's not in-house employees. And so there's the communication and the response time often varies depending on how that funeral home manages their intake, who's answering the phone and who's doing the body removal. And yes, something, if your loved one is in an assisted living or a skilled nursing facility, something to consider, and I didn't think about this until I had this scenario. The family didn't want their loved one removed right away. And so I told the assisted living that, and the assisted living said, absolutely not. This individual has to be removed right away. There's no law saying when a body has to be removed. And so that's something to ask that the hospice team and the family needs to be on the same page about with the assisted living. Home patients are obviously much different. But yes, we've unfortunately waited hours for a body removal team to come due to staffing. There's just, we all know that staffing shortages, and also there's funeral homes that contract out their body removal teams. So this body removal team is working for multiple different funeral homes in the metro area. And so they have a lot more volume that they have to attend to versus funeral homes that keep everything in-house in terms of the intake and the body removal team. And generally those that keep it in-house are much quicker to respond than those that contract out.
Thank you, Kenna. Bill, you've got your hand up.
Yes, I don't propose that this could generalize to other cases besides my own. My wife died a month ago on July 27th. We had the Denver hospice for about 3 weeks. I became aware of her not breathing at 1:30 in the morning. I immediately called the Denver hospice and they sent a nurse out who was here by 2:30 in the morning. She took care of calling the coroner. She took care of calling the mortuary. Just about daybreak, the mortuary came and removed the body. And so I was very pleased with my experience with the Denver Hospice, which is a nonprofit hospice. And I plan to contribute to their foundation in the memory of my wife. But every hospice is unique. Every end of life is unique. Being prepared, as my wife was, and ready, and as our family was, helps a lot. But it also helps a lot to have compassionate people who are there to do what needs to be done at the end.
Thank you. Thank you. So sorry. Thank you for being on this call and thank you for sharing that.
Jill, I would just add one of the things that we have found in hospice care, and Bill, I am sorry for your loss as well. Thank you for sharing. Is every family grieves differently at that end of time. A lot of times there are cultural things too that they would like to keep the body in the home. Asking those questions that are important about just some, I mean, we've had a lot of families that have a cultural process of preparing that body. And making sure that your hospice team is aware if that's important to you and that you have those education pieces before that call.
And again, to speak on, because I'm in senior living, that was an important point. If you have loved ones in a senior living and you do want to hold a vigil and have your loved one in their senior living community, have them remain, please let administration know, because we are a death averse society and we want them gone. We want those bodies gone. And so please, if you have a loved one in any kind of senior living community, and everybody eventually is going to pass away, but if there is some sort of imminence or you're working with hospice, make sure everybody is on board so that your loved one stays and there can be, you know, family honoring that loved one after they've passed in the apartment or room where they have been. Okay, another question. Can hospices help with a natural approach to body disposition, like keeping the body cool, or are they restricted to a certain standard of practice? So Kenna or Kimberly, I know Sue could talk about this as well, you know, with as far as dry ice around the midsection and keeping the body cool if the deceased is going to be there for family to come and sit with them. Great question. I don't know if hospice, if that's something that hospice part of, or a death doula, having a death doula as part of the part of the end of life.
I can't speak for all hospices. I can speak to where Kenna and I've worked together. And for the most part, we accommodate those families' wishes. We have a lot of families that donate bodies for scientific research and so forth. That's never been a problem. I don't know if there's a universal regulatory concern about that. Kenna, clinically, is there? I just know as a team, we really are there to serve the families. So most requests in my years have always been honored. Am I missing something on that, Kenna?
No, I don't know. I don't think so. I mean, I've turned on air conditioning and opened windows and packed the body with cold packs. So yeah, that's what we can do, you know, up until the mortuary comes. But if the question is talking about like body disposition in terms of what happens with the body once the mortuary comes. Hospice doesn't really do that part of it, but we can help identify ways of body disposition.
Would the social worker at hospice have involvement with, you know, if it's a water cremation or green burial or natural organic reduction? Don't the hospice social workers have that for the family to be able to talk with about a more natural body disposition?
Absolutely. And what we do as a team is we reach out to, and Jill, this is just for history here, this is where Jill and our relationship began, is we want to educate our staff on the different ways out there. You know, Kelsey at In Memoriam, I believe she's spoken to this group before. She was a huge advocate for educating my husband and I on what we needed. But in the hospice setting, absolutely, social workers should be well versed on that. If they are not, that would be a conversation you would have with your RN case manager, a chaplain. All of those conversations should be happening bedside numerous times. Probably not right out of the gate, I'll be honest. Those usually aren't the conversations we're having in the first 2 weeks. We're building rapport and trust, but those are gently led back to what we've talked about this entire time, which is death with dignity and knowing what that dignity looks like for your loved one at that time. So, you know, a lot of families don't even know about the different. I didn't know about green burial until Jill informed me. So it's really empowering them and educating them because a lot of people just aren't aware. Kenna, do you have anything to add to that?
Question, let's see, speaking as a funeral home, so we have a funeral home, Anastasia, funeral home representative on the webinar. Speaking as a funeral home, what can mortuaries do to help make a hospice nurse's job easier?
I think the first thing that comes to mind is just to try to have the body removal team call with an ETA. So I always ask for one, whether it's because family is staying bedside until body removal, or maybe family isn't there and I'm there and I'm just trying to manage my night in terms of the other calls or visits I have to do, or my counterpart. I don't work alone. My counterpart, how we need to manage our night. So I think that's really the first thing that comes to mind is just when the removal team has an ETA that we can give to family or to ourselves. That's really helpful. And then I think, no, that's just the first thing that comes to mind. I am sure I'm going to think of something else after this, but really that's the thing that comes to mind right now.
And I would add, for our agency, we make sure there's one person from our discipline team at that funeral service if the family's choosing to do that. A lot of times the family's overwhelmed getting back to us, but when we hear from the funeral home, this is when the service is going to be, we make sure we either have a nurse or a chaplain or a social worker, someone is at that service, bringing full closure to the family.
I know so Kenna, my daughter, she very well could get her first call in 10 minutes when her day starts, her professional day starts at 5 p.m. Does anybody else have any other questions?
I was putting this in the chat, but it's taken me a long time to type it, so I'll just ask. I wanted to ask Kenna, since in Colorado, the family has the right to act as funeral director, do the nurses, yourself included, ever consider just leaving the body in the care of the family without having to sit and wait for the arrival of body transport to an actual mortuary?
Okay, that is an excellent. I didn't know that was a thing. I didn't know that families could act as their own funeral director. So Thank you for for bringing that to my attention. I had no idea. Yeah, and
Okay.
yeah, I would love to learn more about that and how
Yeah.
then if that I do encounter that situation with one of my families, how my hospice agency wants to approach that in terms of what my role is.
Yeah, Kenna, you're not the only one. I think a lot of hospice nurses do not know that that's a legal right of the family. And so because they would be acting as funeral director, there really isn't a legal requirement for the funeral home to pick up the body. And obviously it depends on the family's comfort and wishes around being able to take over and be with the body themselves without, because I'm sure some feel more comfortable having the nurse be there with them, because people in our death phobic society a lot of them aren't comfortable having a deceased person in the house. So it would certainly have to be a case by case, assessment of the family's comfort level. But we have more education to do, obviously.
We're getting a lot of positive comments in the chat. We do this. Will we be able to access a copy of this call? Thank you, Sue. Yes, the recording. It's emailed to everybody who registered, correct, Sue? As
Yeah,
well as yeah.
it'll actually be emailed to everyone who's on the email list.
Yes, okay.
CSC's email list or my out of the box list. And it will be posted on our website and posted on our YouTube channel. So lots of ways to access it after the fact.
Anything else? Wonderful positive chats and personal stories. And we always appreciate, because that's how we connect so deeply with people and know what direction we need to go next as far as the education that we want to do, because we're all so passionate about this and not be in a position in a panic mode to make these decisions. And certainly, my personal philosophy, of which this one grew up with. And so really appreciate all of you being here. And if you have suggestions or want to reach out, Kimberly put her contact information in the chat. I put my contact information in the chat. If anybody wants to reach out, we are all here to help. We would rather have questions asked over and over again than have something be missed.
And when we send the follow-up email to everyone, that will include the recording, we'll also include everyone's contact information. Mm-hmm. Okay. I do have another question that comes up in my work. People, back in the day, people used to be able to go to an inpatient hospice to die. And I had a friend who spent 2 weeks at that inpatient hospice because she was averse to dying at home, and her daughters brought their sleeping bags and camped out on the floor until she passed. I know that is not possible anymore, and that inpatient care is much more regulated. And that one or the other of you would like to explain that to people, because I think that still, if we've had an experience like that of, oh, well, I can always go to an inpatient hospice place. If you'll explain how it works now based on current reimbursement and such from Medicare.
You bet, Sue. I can talk about it, and Kenna, I'll let you, whatever I miss. One of the things we didn't discuss, and I apologize, is exactly what you just mentioned. When a family's averse, the Medicare benefit also allows you to utilize respite care for 5 days. And the reason that's important is a lot of times as the patient begins to transition, families realize, you know what, I don't think I am comfortable. And that's when we will place that patient we have contracts all over, as does Kenna's agency, where you can place that patient for a 5-day respite. You can also renew that 5 days. The other thing to GIP, which Kenna mentioned a little earlier, is we have a lovely facility here at Collier. And if the patient isn't medically deemed appropriate, you can pay privately for that. Jill and I had a gentleman at one of her communities years ago that the family just decided, you know what, we're going to go ahead and put our loved one in this general inpatient, and you pay out of pocket for what we call the room and board. You still get the same care there, but that is available to you. It is only covered by the benefit if the patient is deemed general inpatient. And Kenna, do you want to kind of speak to what those requirements look like?
Yeah, with hospice, at any level of care, you have to meet certain criteria in order to stay on hospice. So that generally, if it's, you know, a routine level of care, and it's sometimes specific to the diagnosis that you're on hospice for, but generally it's weight loss, increased sleep, infections, wounds, changes in activities of daily living needs. And then to qualify for inpatient, where you don't have to private pay for it, where your hospice agency will make an agreement with that inpatient hospice center, and it won't cost the family anything. You have to meet very, very specific criteria, like what Sue said. It's so much more regulated now. It basically, and this sounds awful, I mean, it basically means that this individual has to be in so much pain and needs so many medications that it cannot be managed at home or in a senior living community just with oral medications alone. Oftentimes you need, you know, sub-Q or even IV medications, which we don't do IV meds in hospice, except generally in an inpatient setting, or we're titrating off oxygen. And that needs to be managed in an inpatient setting. And that really, yeah, when I've had to put patients in GIP, it's really hard. It's really hard for the individual. It's really hard for the family, because it means that person is in so much pain. But that is unfortunately how the Medicare regulations work now. And then that means that they can get the inpatient level of care without having to private pay for it, or you can private pay for it if that person doesn't meet GIP criteria, but doesn't want to die in wherever it is that they call home.
And then Kenna, it's true that if a particular hospice does not have their own inpatient unit, then they can access a room in a nursing home. Is that correct?
Yeah, so most hospitals don't have their own inpatient setting. So yeah, we can do inpatient at Collier, which is an inpatient hospice. We can do it at a nursing home or a skilled nursing facility. We can do it in a hospital, you know, a medical hospital.
Yeah, thank you.
And I think another thing, Kimberly and I did one of these a couple of years ago at a church in Arvada, and it was very well received. And Kimberly, please correct me. Somebody lives about a month longer when they're on hospice. So it's just this beautiful opportunity, and it's a gift of time for you and your loved one when they're on hospice, that their quality of life is better and they live longer. Correct? 28 days, 30 days?
Yeah, well, you were right in the middle. It was 29 days last day I checked. So right there. But yeah, people don't realize that. And that's why we talked a little bit about graduating out of hospice. A lot of times you will find people really start to improve because they're getting all of this attention and love and care. And, you know, it's not uncommon for me to hear about my RN case manager picking up Mr. Smith a milkshake on her way to come see him. And that's where we see that their quality of life is really improved, and they do. It is statistically, last I checked, it was 29 days you live longer on hospice.
And then another question in the chat, what Colorado state agency would have hospice ownership info? Is that DORA? DORA is Division of Regulatory Agencies, like Kenna has her nursing license would be under DORA. It's all public information. I do not know the answer to this question.
I believe it's going to be where we receive our license, and that is not a question I feel like I can speak to intelligently. I can sure find that out, but I would think it would be the Department of Health issuing the hospice license would be able to speak to ownership.
So CDPHE?
Right.
Yeah, we don't know. That's
I don't want to say, I like
well
I said, I
done.
can't speak confidently. Yeah.
Yeah, Colorado Department of Public Health and Environment is CDPHE. Don't know. We'll find that out and blast that out. Sue, great question. Anyone? No. Wonderful. We're at almost 5 o'clock. Gosh, and most everybody stayed on. So thank you. Thank you. Here we go. Colorado Secretary of State website online filings may reveal ownership info. Thank you, Galen. Yeah, we'll research that a little further, and that's a good one. No, we really appreciated it. If anybody has any ideas for future webinars, something they want to hear more about, Sue will email out contact information. Please reach out. We want you all to be very, very well informed way before you need it. You're on mute, Sue. Sorry. Mute.
Thank you, Jill. And we all need to also need to put in our little plug for volunteers, because if you're in alignment with our mission to educate consumers on all things end of life, and especially funeral consumers issues, we are a all volunteer board. It's 7 of us at this point, Jill. We're all nice people. We have fun at our meetings. And it's just us who are keeping up with the price survey that is like core to our work on our website right now, which is the listing of all 300 plus funeral homes and other funeral establishments in the state of Colorado, and constantly needing to update the pricing on there and the information about ownership. Ownership does make a difference. All that information we keep having, we get through the whole thing and then we got to start over again. So we're always happy to have someone who might like to do some administrative stuff also, besides being on the board. You will all be receiving an email, as we said. And in the meantime, if you haven't attended some of our other webinars, you can check out our YouTube channel. I posted the link there, and I'll send the link out in our follow-up email. Topics like ask a coroner and how to stay in charge at the end of your end of life, which was a compassionate choices presentation. What does a death doula do? How do I leave order, not chaos? Ask a funeral director, and a full hour and a half on water cremation. That was outstanding. And then our very first webinar, I just love the name that Jill came up with, which was 6 feet under, or which was about alternative options for body disposition. So right at 5 o'clock, want to be respectful of everyone's time. Thank you so much for being here. And thank you to Kenna and Kimberly for great conversation around hospice. And hopefully, I know that they answered a lot of your questions and wonderings about what hospice really is. And thank you, Jill, for facilitating. So thank you, everybody. Have a good rest of the night.
Thank you, everybody. It was great. Thanks.
Thanks, Gary.
Thanks, Gary.
Thanks. It was good to be. I'm grateful.
Yay, thank
Both,
you.
I learned a lot, and it's a lot to share. And I think that's what you don't know your audience. That's the other, I was thinking about that. I mean, it is a webinar and it's not a Zoom meeting. but it moves a little bit into that when you're with the topic we're dealing with, and then, which is important to everybody, back to we're all going to die, and we know people dying. And I don't know how it quite get it that way. It's like not a death cafe. I was going to go with that, but how that Jimmy Carter thing just